Okay, should we kick off? I'd like to welcome everyone. Do you want to take your seats, and then we'll just kick off in just a second. There's one or two more people arriving. So welcome to the annual lecture for the Center for Clinical Epidemiology and Evaluation. It's a great pleasure to welcome our speaker, Dr. Andreas Laupacis, and welcome all you for coming along to the lecture, and just remind you that we do have a reception afterwards, so please feel free to stay, and we'll take a bite to eat, hopefully, and engage in further conversation. So the topic we have for the lecture this year is engaging patients and citizens in research and healthcare decision-making. And we've chosen this topic mainly because it's dear to many people's hearts, including ourselves. And certainly I've been talking a lot about engaging patients in healthcare decision-making, both at the front end in terms of the individual treatment decision, but also through to engaging, having a patient perspective in terms of policy decision-making. And so when we were thinking about this as a topic, and then who we might invite to speak on this topic, then Andreas's name obviously was top of our list of people who could speak to this, in part because of his work on the website healthydebate.ca, which hopefully many of you have visited that website and follow the discussion, partly because Andreas also has a stellar track record, both as a researcher, as a clinician. So he still is actively engaged in treating patients. Has a policy perspective and has been involved in many policy fora, and sits on a whole variety of boards of policy-making bodies. But also just that he's an active debater. So I think he'll talk about his tweets and Twitter and his engagement with that sort of debate environment. And in fact, he's encouraging me to sort of take that tentative step over the edge and actually post my very first tweet. Because apparently I hadn't realized this, but I do have followers, but I've never actually tweeted. 19 followers, but I've never actually tweeted. So I'm taking that lesson to heart. So I want to do that. But it's great to have Andreas, and we're very grateful that he's been with us for a couple of days now, and we look forward to his lecture. So what we're going to do is have the lecture. We are going to have some time for some discussion, so if you have points that you want to raise in plenary, then Rob McMaster, the director of the Research Institute, will facilitate the discussion, but there will be some time afterwards for some individual discussion, both with Andreas and others from the centre. But without any further ado, I'd like to welcome Andreas and invite him to provide the lecture for us this year. Thank you.
Thanks. You didn't realize that, Sterling, but while you were standing up here on the screen there, you had a sort of red bullet right on your forehead. So I'm going to try and avoid that because it was a bit disconcerting. Really delightful to be here. Thank you very, very much. I'm going to start on a slightly sort of sad and reflective note that I wasn't planning until this afternoon, actually, when I found out that a guy by the name of Donald Lowe has died today. I don't know if any of you know Donald, but he was a world-class infectious disease expert at Mount Sinai. And those of us in Toronto who lived through the SARS outbreak, he and Sheila Bazarer, who also sort of tragically died a few years ago at a very young age, were really the kind of incredible, they were kind of the rational and then the informed voice that got most of us in that community through the SARS outbreak, actually. Incredibly honest, incredibly articulate, incredibly able to phrase and actually discuss scientific issues with the press and the public in a way that everybody understood. And everybody just really respected the two of them. And the title of the talk is around patient engagement, and in the middle of that SARS outbreak, they sure weren't doing a lot of engagement, but they sure were doing a lot of communicating. And I think Don was a real master at it, and part of engagement is being a good communicator. So I didn't know him that well, but I'd like to sort of dedicate, Don, wherever you are, this talk to you. And if I screw up, you didn't have anything to do with it. And if it's a good talk, you can take credit for it. So it's sort of a sad thing today. Just a brief intro. This is about both patient engagement in research, priority setting, as well as a bit of thoughts about patient engagement in the design and the running of the healthcare system. So I'm going to spend about half of the time on each of those. I'm going to largely focus on one example of each of them, reflect on some of the lessons I've learned. This is not a systematic review of the literature. This isn't a highly academic talk. It's a fairly personal one. And I'm one of these guys that every sort of 6 years or so, I've kind of changed the focus of my career. I mean, I've not gone into abstract painting or anything, but I have changed, and this is sort of a new area of interest for me. So one of the reasons it isn't an academic talk is I don't know enough academically about this to give an academic talk. But it is something that I think is incredibly important, and I'm pretty sort of passionate about. And I suspect there's many of you in the audience here who are actually much more knowledgeable about this than I do, and look forward to a bit of a discussion in the question period and in the drinks and food section afterwards. So I'm starting with this slide. This is a gentleman I've never met. I've had an email interaction with him, and his name is Michael Katz, as you can tell. He actually has multiple myeloma. And those of you who know anything about multiple myeloma, it's a pretty nasty cancer. And he was a member of a patient advocacy group. And many patients with multiple myeloma has traditionally been treated with some chemotherapeutic agents and then high-dose dexamethasone, which is a steroid that at high doses has very nasty side effects. It causes lots of facial swelling and bloating. It can make some people feel really hyper. Patients basically didn't like it. And what patients like Michael and others actually realized was that many of the patients actually weren't taking the high-dose dexamethasone that they were being prescribed. And they actually wondered whether the high-dose dex was necessary. And the story I heard was that Michael and patients were instrumental in persuading oncologists in the U.S. who were part of ECOG, the Eastern Cooperative Oncology Group, to actually design a study comparing conventional chemotherapy plus high-dose dexamethasone with conventional chemotherapy plus low-dose dexamethasone, with the thought that if the low-dose dexamethasone was as good as a high-dose, one would use that and avoid the side effects. And I actually wondered whether that was really the case, and I sort of emailed the principal investigator of the study, who happened to be at the Mayo Clinic. His name is Vincent Rajkumar. And he actually did indeed, I'll just finish the story about the trial. So they actually did design that trial. And I think there's no doubt that that trial would not have been designed had patients not advocated for it. And it was designed as what's called a non-inferiority trial. They expected to see, or they hoped to see, that the low-dose dex was as good as the high-dose dex, but didn't think it would be better. It turned out actually that the Data Safety Monitoring Board recommended stopping the trial early because the one-year survival was 96% in the low-dose dexamethasone and 87% in the high-dose or the standard dexamethasone. In other words, there was an absolute difference of 8% in mortality, all-cause mortality, in people that got the low-dose dexamethasone. So here's a patient-driven RCT that actually saved lives. And I emailed Dr. Rajkumar and said, is this true? And his response was, yes, this is true. The trial was published in the Lancet Oncology, and I've got just to prove that. Hang on, how do I? Yeah. And you'll notice that Michael Katz is one of the authors. The trial, this was a trial I led for the Eastern Cooperative Oncology Group. The trial found that low-dose dex saved lives. It's now the standard for almost all new myeloma regimes to use low-dose dex. The idea for the trial came from patients through Michael Katz, a myeloma patient support group leader and patient rep, who posed the simple question, in an era of new drugs, do we still need the toxicities of high-dose dex? And argued that only the publicly funded groups rather than industry can answer these types of questions. We did the trial looking for a reduction in side effects, but found even more benefit, a true survival benefit. Mike was an author on the paper. The role patient input through him played in this trial has been highlighted in meetings and lay articles, but not in the medical literature as far as I know. So I thought that was kind of interesting, right? The patients kind of talk about it among themselves, but actually I only found out about this because I was giving rounds about actually the dialysis work I'm going to show you, and one of the hematologists at St. Michael's came down and said, hey, have you heard of this story of Michael Katz, right? And then he says, let me know if further questions. We are not listening to the patients enough. So I put this up here just sometimes I think the more kind of hardcore, cynical clinician, not that there's many of those, sort of thinks that patient involvement is only around the, kind of the softer quality of life issues, the psychosocial issues, and I think that's incredibly important. But just to reassure those that don't think that's important, patient involvement they actually do care whether they die or don't, and can lead to the design of studies that would never have been designed by the scientists, or probably would have taken a long time to be designed by the scientists, that only happened because of patient involvement. I just put this up here. I'm not going to belabor on this, but why involve patients in research? I think there's a whole bunch of reasons. They live with the disease. As I just told you, they'll sometimes identify research priorities that are different from those of us who are researchers. There are many ways that they can improve the quality of the research by improving recruitment rates, by a whole bunch of other things. They also have very important insights into outcome measures. An example that I'm aware of is when you consult patients with urinary incontinence, for example, and say, what's really important to you as an outcome measure? They talk about measurement of quality of life, depression, etc. Turns out that the primary outcome used in most studies of new drugs for urinary incontinence are number of incontinence pads that you use per day. And the patients sort of say, really, if my number of incontinence pads goes from 10 to 8, even if it's statistically significant, that's not all that important to me, right? And so I think work that's been done in arthritis recently has shown that, fatigue, if you talk to patients, is a much more important outcome measure than actually rheumatologists realized. They thought it was all about pain. So I think they can really help there. And the bottom part is sort of justice and fairness. These are the people that are good enough to come into our clinics and spend their time to be in our studies. They're good enough to be poked for IVs and tests and all the rest of that stuff. I mean, surely they have a right to have some say into the kind of research that is done. This is Sir Ian Chalmers, known to most of you probably because he's the founder of the Cochrane Collaboration. He's also, as his career has progressed, the founder of the James Lind Alliance. So James Lind, for those of you who don't know, is a British naval surgeon who's did that randomized trial of, that's why Brits are called limeys, right, of Lyme versus other things, and showed that citric acid prevented scurvy, supposedly one of the most famous and influential randomized trials ever, and why Britain took over the world. The James Lind Alliance, though, was formed and they've actually got a pretty good website if any of you want to visit it, was formed basically to bring together patients, their carers, so their spouse or kids or friends, and the clinicians who look after them, so the nurses, the physios, the physicians, who aren't necessarily the research clinicians, but the clinicians who look after them, to together say, what are the top 10 research priorities in the particular disease that we have. It was initially started as a grant from the National Institute of Health Research. It has been so successful in the UK that it's now been integrated as an integral part of the National Institutes of Health Research. So it's no longer sort of standing on its own. And they've done, I'm going to briefly describe to you what we did in dialysis. They've done a number of research priority settings, I think in about 20 to 30 diseases right now. And if you get on their website, you'll see what they're up to. So I'll just very briefly describe the project that I had the incredible fun of being involved with. And it was basically to consult and involve dialysis patients, clinicians, and carers across the country in identifying the top 10 research priorities from the perspective of people on dialysis. And this is the steering committee that ran it. Sally Crow on the upper left is one of the people that's worked with Ian, and so she's an expert facilitator in the JLA process. So she helped us and actually came to Toronto to do the final workshop. 5 of those people are patients. 4 of them are patients. One of them was about to start dialysis. The other 3 were on dialysis. One of them was a caregiver of her mom who's on dialysis. 2 of them are nephrologists at the University of Calgary. And one of them is the Vice President of Research at the Kidney Foundation of Canada. So that was a steering group. So my observation, with all due respect to the CHR, is when they talk about patient engagement, it's often one person on a committee of like 12 or something, right? So there were more patients on this than there were scientists. And we actually spent the better part of a year having a teleconference every 2 weeks for an hour, shepherding this whole project through. Probably worthwhile mentioning that the mom of the caregiver died during this project. The person who was close to being on dialysis started dialysis during the project. One of the people who was on dialysis got transplanted during the project. And one of the patients on dialysis, many times that we had our teleconferences, was admitted because of complications of dialysis. So for these kinds of, patients are pretty sick. But they all stuck with it. But you got to be kind of flexible around this kind of thing. And the fact that they stuck with it, I think, shows that they thought it was worth their while doing. So very briefly what we did, we identified and invited potential partners here. There weren't that many potential partners. It was, the Kidney Foundation of Canada, the Canadian Society of Nephrology, the nurses who look after people on dialysis have their own society, etc. The funding, by the way, largely came from the CIHR through a variety of, we got a workshop grant, and then Braden and Brenda in Calgary had a team grant. We posted a national survey on the web, which we advertised as widely as we could, which asked patients and carers and caregivers to identify what they thought were the top unanswered research questions for patients with dialysis. We also, because we thought really sick people on dialysis wouldn't probably go on the web, we actually at 6 different dialysis centers handed patients hard copies of the questionnaire and encouraged them to fill it out. I'll show you how many potential questions we got. We sort of refined that massive number, it was about 1,800 actually, down to 30. The steering group did that. And then we held a workshop with about 26 people or 30 people in Toronto in June to narrow that top 30 down to the top 10. 323 people responded to the questionnaire. To be honest, never having done this before, I was a bit disappointed with that. I thought, geez, we've kind of gone all across the country and we've tried our darndest, but I think just tells you that people who are, relatively sick and have got other things in their life going on, that many of them are just not going to spend their time doing this kind of thing. But what was striking to me was that each respondent on average had more than 5 suggested unanswered research questions, right? We also looked at clinical practice guidelines to identify, often the guideline will say there's lousy evidence to support this recommendation. We felt that was a research uncertainty, so we threw them into the mix. And those questions were kind of lumped. So out of the 1820, there were many that said, we want research to figure out how we can better manage itching on dialysis. So they would all be, lumped into one itching category, right? So the steering group met repeatedly by teleconference, and we identified a top 30. The top 15, to be honest, were very easy to do from the responses. The 16th to the 40th, where there's a fair amount of judgment involved. And then there was a workshop of 34 people from across the country. There was at least one person from Vancouver. I think there were 2 people from Vancouver, actually, who came to it. We had people from Vancouver to St. John's, Newfoundland, attend, and through a nominal group process came up with the top 10. Here's the kind of a picture of the group. You can see the gentleman on the bottom right is a fairly frail elderly gentleman on dialysis. He actually had to leave about an hour early at 3 o'clock because the emotional intellectual overload was just a bit too much, but everybody else sort of stuck out. He was there with his son, who was his caregiver. I was sort of terrified that this stairwell was going to kind of collapse as we were standing on this thing. And we had the top 30 questions on sheets of paper that I won't go into the process, but that helped kind of in the nominal group process. Small groups sort of deliberating about things. I actually sort of love this picture. This is a person on dialysis and her daughter, and just the kind of the look there as they're talking. A person on dialysis, his wife, and a vascular access nurse actually in this picture. And I'll just show you the top 10. And actually, I'll just leave them up there, and you can read them. My sense is actually they're a pretty good spread of different kinds of research questions. And another thing that struck me was, for example, there were that one, number 5, on psychological social impact. I would guess that most of you, and I would have thought that would have come mostly from the patients. Actually, that one came mostly from the clinicians. So it was interesting how there were some of these questions that all 3 of the groups, caregivers, clinicians, and patients, all identified as really high. There were others that were more identified by one group than the other, and we're actually sort of putting that in the paper we're writing up. And there's the final top 10. And let me just remind myself what's coming. Yeah. So, if I think, so this is the first time I've ever done it. And if I reflect on lessons learned, certainly, patients and caregivers, some of them anyway, are keen to be involved in this kind of priority setting process. I mentioned that I was a bit disappointed by the number of respondents, but I'm told that is kind of usual. But certainly those that did responded very thoughtfully. One of the things that was really interesting, because I facilitated one of the small groups, was watching how the clinicians and the patients interacted. And very often the patient would sort of say, well, I have a huge amount of problem with X, and would tell their story. And then they would look to the clinician and say, but am I an aberrancy, or do you see this a lot? And actually having the patients and clinicians and carers in the same room, I thought was really, really, actually much stronger than I think just having the patients alone, because the patients spontaneously, one of them sort of, they didn't want to put one of their priorities on the top 10 if they were the only one that had that issue, right? So they kind of validated things with the clinicians, but they also, I thought, kept the clinicians pretty honest. There's no question that this group was not representative of all people on dialysis, so only 1% of the respondents were First Nations, for example, and there's a much higher proportion of First Nations people on dialysis in the province. And also, I think we underestimate, if you look at the mean age, it's a little less than the average of the respondents, or the average age of people on dialysis, and I think we didn't get the really frail elderly on dialysis, and so, it's I think a methodology for this kind of, it's a methodological challenge for this kind of thing that hopefully will sort of work out over time. And actually there's kind of we actually sent the survey that was on the web, we pre-tested it with a few patients, and actually Annette, who's the caregiver in Nova Scotia, shared this asked one of the patients or one of the other caregivers to get on the website and try the questionnaire and give us some feedback before it went live. And this person said, honestly, Annette, I'm exhausted mentally and physically and must admit the survey form didn't encourage me to reply. I'm not slamming the survey, only giving my own feelings. I can't even get Mel to make a decision as to what he wants for meals at the hospital, so to ask him the questions for his responses would be difficult. Sort of a compelling reason as to why you might not want to respond to this silly survey, right? But I think it just sort of illustrates, one of the challenges of reaching and getting the priorities of people that are particularly frail and ill. Nonetheless, I think this is a lot better than what we've done before, which is never consult them. And I guess my final observation would be that it was a lot of fun, but it was a lot of work. It was a lot of work. And so I'm sure keen to do this again in other groups. I think it's a pretty cool methodology. But if anybody wants to do it, they've certainly got to be willing to put in a fair amount of effort. Our next steps are to share this with research. Actually, I just sort of emailed my executive assistant this afternoon the sort of final draft to people like Diane to sort of say, like, here's what we did and here's the top 10 and Hope that you'll share it with your research communities and maybe even use some of this for an RFA in the future. And we're in the process of actually, once we finish the main paper, is actually to compare how closely recently published papers in the area of dialysis and recently funded dialysis grants match onto those top 10. And I'm sure there's going to be some overlap, but I'm sure there's going to be, the Venn diagram isn't going to be like superimposable, right? And so I think that'll be really, really interested in. And I've talked to Ian Chalmers, and I'd be very keen to actually establish kind of a JLA Canada. So if anybody here wants to give us some infrastructure support to do that, I would be happy to buy you a glass of wine after at the reception. So that's that's the section on patient engagement and research priorities. And I would just, those of you who are interested, I would just refer you to, I don't know whether it's me up here in that monitor, but everything looks slightly blurred on the screen. But there's an outfit in the UK called Involve, which is actually involves patients are involved in research. And there's an excellent paper that sort of explores the impact of involving. They have actually a large number of publications, but the point of putting this up is I've just talked about patient involvement in research priority setting, which is one very small part of patient involvement in research, right? They can be involved in the design of the study. They can be involved in encouraging recruitment if they've been involved in the design of the study. They can be involved in knowledge translation of the results at the end. So just to make a point that I've just talked about a very small part of that. So this blank slide is just to remind me to kind of change my gears here. And so we're now I'm going to talk just a bit about how I ended up sort of editing with a number of other people the website healthydebate.ca. And for me, the story really started when I was chairing CDAC, which is a Canadian Expert Drug Advisory Committee, which is basically the committee that recommends to all publicly funded drug plans in the country except Quebec, which drugs should be paid out of the public purse. Very, very important, very hard, very value-sensitive decisions. We had a committee, there was a couple of people actually from Vancouver on it, that I thought we did our darnest, and we struggled with these. I mean, sometimes it was kind of obvious that the drug should be funded, and other times it was obvious it shouldn't, but we actually struggled with some of these tough things. But one of the things that just really struck me was, like, we didn't have any patients on the committee, and it just didn't seem the right thing, given that we were talking about values and the lives of patients. And so that kind of got me increasingly, and one of the things I was happy with before I resigned as a head of CDAC, they did agree to put 2 patients on the committee. But again, that's, 2 patients on a committee of 10 or 12 or whatever, but nonetheless, an important step in the right direction. But that sort of got me interested in patient involvement in decision making. And so with Wendy Levinson, who's the chair of medicine at U of T, and Roger Chafe, who's now a health technology assessment guy in Memorial, we actually did a project that was probably the most fun thing I've done in the last few years, which is we established sort of this citizens council. We basically hired a company to random digit dial in Toronto people and said, would you be willing to spend 3 weekends a year with these folks that you've never met at the University of Toronto to sort of deliberate about value-sensitive issues in healthcare. And we asked them to try and get a group of 26 citizens who were reasonably broadly representative of the social demographics of Toronto. And so it's probably the most nervous I've been in the last 5 years walking into that room, because we'd never met any of them. We hadn't pre-screened them. They'd volunteered. By the way, they couldn't sort of work in the healthcare system. They couldn't work for a pharma company. They could have a disease, but they couldn't be an advocate for the Heart and Stroke Foundation or whatever. They were sort of citizens, if you will. So this is sort of citizens, not patients, right? And our feeling was that, citizens pay for the healthcare system. They actually use it. Their loved ones use it. They probably should be engaged a bit more in how it's kind of designed and run, and we should be consulting them a bit more. So they actually did a very good job. This is definitely blurred. Of getting this group. This is actually, I think, the first time that we met. Actually, Wendy Levinson, chair of medicine, is the person in the front on the right, and I'm somewhere in the back. But we basically spent the better part of 3 years, like 3 weekends over 3 years. And these are the kinds of things we asked them to deliberate about. The top one actually was the Ontario government had decided that there wasn't enough evidence for PET scanning to pay for it out of the public purse, which is a very controversial decision. And we sort of said to them, we'd like you to deliberate about, like, do you think that's a reasonable decision or not? If you do, why? And if you don't, why not? And what would you suggest the government do? And to just be clear, we did not try to, there was no attempt to force consensus here. Like we said, it's perfectly fine if you folks disagree with each other. We just want you to have a respectful dialogue with each other and to articulate why you disagree with each other. And the format was basically a weekend, Saturday and Sunday through till about 3. In the Saturday morning, we would have people actually pretty carefully chosen to be able to present things to the lay public in a non-technical manner, but also not to dumb it down too much. And then the citizens could sort of ask them about things, and that was sort of the morning, and then they would deliberate in smaller groups and then a bigger group, and we would actually, tape record all this, and we actually put together the summary of their deliberations, sent it back to them, got them to edit it, and published it. And some of these have been published as papers. Some of them have never seen the light of day. They're actually all, if you want to see them, on the Healthy Debate website. It was a really absolutely fantastic experience. This is the picture of them on the last day before when we decided it was a CHR grant and we ran out of money basically. And we were very clear to them that, we weren't the decision makers. So you're going to deliberate about this, but we'll share some of your deliberations with the people we know in Ontario, but we're not going to fool you to think that this is actually going to impact upon care. The lessons learned from me for this was that non-expert volunteers can deliberate very thoughtfully about complex issues if you establish the ground rules early on, which is this is a respectful deliberation. It's not a debating society. We're not trying to force consensus here. If the material is presented to them in a sort of non-jargony way, and that they're given sufficient time to deliberate. And so many of these people didn't have a high education, but they got it. They could deliberate and they could talk. And my observation would be often they didn't come up with things that were all that different from what those of us in the healthcare system would come up with, but there were often important differences. So just to give you one example, one of the things that we asked them is, what do you think Ontario's hospitals should publicly report about their quality of care? And for me personally, it's actually changed fairly profoundly the way I think about performance measurement in hospitals, in that they were all very interested in sort of the hard metrics. What's the likelihood I'll die from a myocardial infarction if admitted to St. Paul's versus Vancouver Coastal. But they also placed much more emphasis than most of us in the measurement area did upon the personal aspects of care. It's really important for us to know that, if my granny is freezing and emerge, someone's going to come and give her a blanket. And so, to me, in my own mind, I'll now place much greater emphasis upon the patient satisfaction measures than I did before this process. Around the PET scanning, most of them said, we think it's pretty reasonable that the Ontario government doesn't pay for PET scanning, actually, because it doesn't sound like there's evidence that it really impacts upon outcomes, and it's really expensive. But you know what? The Ontario government at the time had funded studies to answer the questions about whether PET scanning really was cost effective. And those studies patients weren't being enrolled. And they said, but you know what? If you say that you're going to wait until you have those studies done, you better make sure that those studies get done in a reasonably rapid way. Because if you don't, it just looks like you're using the research as a crux for deciding not to pay for it, right? And again, these are people that didn't know what a PET scan was the day they walked into that thing. I thought that was a pretty kind of sensible comment, actually. So it was, and then the other comment would be that in no way did they ever kind of unreasonably demand resources. As a matter of fact, often they sort of say, shit, I'm paying all these taxes for healthcare, and I don't think we should pay for that because my taxes are going to go up even more, right? So there's a lot of concern around those of us, I think, within healthcare that if you get citizens, because politicians, I think seem to think of citizens as the people that are screaming at them in the middle of an election, as opposed to citizens who are thoughtfully dialoguing about something that they're getting informed about. So there was none of that. They indicated to us that they read the newspapers very, very differently, much more aware of the politics of healthcare than they did before, and I actually believe them. Finally, they were surprised by a bunch of things. And for this audience, the one that really struck me the most was they were really shocked about how much experts within the system disagree with each other about the same thing. So, the PET scanning thing, they saw Bill Evans, who was the head of the cancer clinic at McMaster, an oncologist, a person who treats people with cancer, arguing that the government should not fund PET scanning because there was no evidence it was cost effective. You have Al Dreger, the head of nuclear medicine at the University of Western Ontario, more or less saying it was unethical not to provide PET scanning to people with cancer. And they're sitting there going, shit, these two guys seem like pretty smart, kind of sensible dudes, and they're looking, I think, at the same evidence, and they're telling us entirely different stuff. So I think it made them much more kind of aware about how kind of just uncertain a lot of the evidence that we try to pretend is certain is. So I did say this was about healthy debate. So this was really great, but my weekends are valuable. I love my wife. I don't like spending a lot of times on my weekends working. And these were 26 people, and it didn't have a big impact. So out of that, in a kind of slightly convoluted way, came the website Healthy Debate, which has been going on for 2 and a bit years now. This is a screenshot from it this morning. The tagline under there is unbiased facts, informed opinions. It's a slightly obnoxious sort of tagline. How can you ever have unbiased facts? But that's kind of what we're aiming for. And those of you who have not seen it, the hope was to present information about how our healthcare system works to both people within the system but also people who are outside the system in a manner that's kind of understandable but doesn't dumb things down too much. And we also hope that this might be a website that would be of interest to students who are in the healthcare industry. And it's basically, I don't know whether this works or not, but yeah. So it's divided down into articles. We publish one of those a week. They come out on Thursday morning. The one this week is urgent care. Why aren't we measuring wait times for people that really need urgent surgery versus elective surgery? We have opinion section where people actually send us in blogs or opinions about whatever they want to send in. We do edit those. And then we have a sort of a comment section. Not to be able to see all of it, but just the two people that are the writers are like 150 years younger than me, so they're very into the social media, so they're very active on Twitter. There's a section so you can see here, these are the tweets that have come in about healthy debate in the last few hours. There's a comment section for people that have comments. And that, by the way, I was slightly disappointed there's not as many comments as I would hoped, but there's way less really dumb stuff that you see in the comment section of the Vancouver Providence. So on reflection, I think I'm pretty happy on the kind of quality-quantity thing of the comments. We have the opinion section, and then we have and at the very bottom, and I'm just going to end by talking about this briefly, is a section called the Patient Navigator that's written by Lisa Priest. Some of you may know that Lisa is an award-winning Globe and Mail journalist who actually quit the Globe probably a year and a half ago and went to work for Sunnybrook Hospital. Actually in there, I'm actually not 100% sure organizationally where she was, but she was sort of in the communication, patient engagement, PR part of the hospital. And she would get all the patient complaints, or many of the patient complaints. And then she would use those to write, I thought, extremely well-written articles about, why do hospitals do this? So an example might be someone would write in and say, I'm 85 and my 86-year-old husband was in for pneumonia and the hospital kicked him out and I just don't feel ready to take him home and how could the hospital do that? And so she would write a story about, hospital doesn't really like to do that, but there were 10 people sitting down in a merge and I thought actually she did a really good job of that. And we're talking about involvement with patients. I think Sunnybrook actually took quite a big risk and it's interesting actually, the Ottawa Hospital has just hired a woman by the name of Pauline Tam, who was the health journalist for the Ottawa Citizen. So I think a lot of journalists, actually, it's not a good time to be a journalist. So no, seriously, they're being let go left, right, and center, and so they're actually, they're excellent writers. They're smart people. Lisa's replacement is actually going to be, I'm not sure whether it's public or not, but it is going to be a pretty prominent journalist as well. We actually, just basically posted Lisa's stuff up there, and our sense is around the traffic, a lot of the patients were actually going to that part of the website because they found it very interesting for them. So, we're actually just in the process of doing, so my quick take on the successes and disappointments of Healthy Debate, we have been much more successful and much more sort of taken up by, and by the way, I should have said, it's focused on the Ontario healthcare system, and we just recently started to focus on Alberta as well. So right now we've got an Ontario, Alberta, and our editorial team consists of 5 people from Ontario and 5 from Alberta. But we're still writing the stories from Toronto. In Ontario, the site is read by a lot of people within the healthcare system, way more than I would have thought. And so when Deb Matthews, our Minister of Health, was being grilled by the opposition member about something to do with the Orange scandal, he handed her a paper and said, Minister Matthews, have you read this paper? And she says, no, I haven't. And he said, well, what do you read? And the first thing out of her mouth was Healthy Debate, which we were kind of arrogantly pleased about. And it is in Hansard. I'm not making this up. And I've had many CEOs email me and say, your 2-page description about how the way of changing hospital funding on Healthy Debate is the clearest thing I've yet seen, and I've shared it with my senior management. So that's been very satisfying. And personally, I'm getting pretty old, and I've been in the system for a long time, and I think I know the system better than most people, yet every time we write a story, I learn something, which tells you how complicated the healthcare system is. So I think we've played a role there to just kind of educate people within the system. Where I'm a bit disappointed is that I don't think we've engaged the public quite as well as I hope we would. It's clear from looking at some of the comments that there are just regular members of the public reading it, but I don't think quite as much, and we're establishing a public or citizen advisory body, which we hope will help us sort that out. Because we had this sort of slightly naive, it's almost kind of hokey, right? The blue deoxygenated blood gets oxygenated by Healthy Debate and goes back. But, the sort of naive, but this actually honestly was sort of what I was naively wanting to set up is, you're a citizen, you want to improve healthcare, healthcare is important to you, you have opinions, you're actually not sure what the truth is. Healthy Debate might be a place for you to go to get some of that, and at the end, you are a bit more of an informed voter when you go to the polls or when you're interacting with your politicians, your voice is stronger, you might be a better advocate, you understand the system better. We've got a ways to go for that, and we can talk about that if you want the question period. I'm just going to end with this, and Sterling way over-exaggerated my social media capabilities in his introduction. But this is a very interesting, when I look at how hospitals involve, and I spent a bit of time yesterday morning looking at the Vancouver Coastal, Twitter feed. And it's very kind of formalistic, if I might say that. It's sort of like there's a meeting here, and there's, here's a paper by Sterling Bryan with a link to it, that kind of thing. Sunnybrook has really gone out on the limb here, I think. So I actually went on their Twitter feed yesterday, and these are from a while ago, but if you look at the one on the right first, there's a person sitting in the merge saying, had the first terrible experience with a doctor at Sunnybrook, reluctant to allow him to treat my dad. That's at 7:37 in the morning. At 9:33, someone from the Sunnybrook communications department says, we hear your frustration. Would you consider sharing your thoughts? And here's the patient kind of complaint place to go. The person a day later says, Department of Patient Experience is just fabulous. I'm so impressed that I'm going to volunteer. Sunnybrook says, glad we could help you out. Now, I'm sure they've selected these, right? Like they're not all the way. But then, interesting, the one in the middle on the top, waiting hours for care, and then some guy sort of says, watch it, dude. Sunnybrook really actually follows the Twitter feed, and then the other guy sort of says, well, yeah, you're right. I never got contacted by Mount Sinai, but Sunnybrook is following what I'm doing on Twitter, right? And hearing patients' complaints and their positive things. So, if you get on their Twitter feed, you see mostly actually patient complaints. Saying, I kind of didn't like this, and will you help me out? Yet you also see them actually actively trying to help that. And I wonder whether this isn't the place where we're going to be, going down the future. And it was interesting to me. Hang on, that was the wrong. It was interesting to me that when I looked at the number of Twitter followers, Sunnybrook has got 3 times as many as does Vancouver Coastal or St. Mike's. And I wouldn't be surprised if it's because they're starting to get interactive in a meaningful way. And they're not just an advertising kind of Twitter feed. I have this picture up. Now this guy, if you want to follow somebody, I suggest you follow him. He's a general internist at St. Mike's. Even though he's a really young guy, one of the most astute policy minds I know. And the story about him for me was I was sitting down with some medical students a few weeks ago, and one of them said to me, I know at least 3 of my classmates who want to do their clerkship at St. Michael's Hospital because they follow Irfan Dalla on Twitter. That kind of blew me away, right? We advertise with brochures about why you should come to St. Mike's and stuff. These folks had just started following this guy, and they basically said, shit, if St. Mike's is going to employ someone like this guy, maybe that's a place I want to go do my clerkship. And he, if you look at his Twitter feed, in my opinion, he'll do things like, medical student tip of the week, and there'll be a link to a particular, like he's not talking about like I had sushi for dinner last night and stuff, right? He's providing really useful, varied, interesting information. And I can almost guarantee you that there are no medical students that have decided they want to do their clerkship at St. Mike's because they're following the PR Twitter feed from St. Mike's, right? And I'm not slamming the PR folks, but because you got to be correct and you got to be careful, but it's just not that engaging. And so I think as organizations look forward in the future to bringing the kind of people they want into their organization, like this is actually one way to do it. And he's got. I put down Steve Morgan here. He's obviously, those of you who know him, he's a health economist here at UBC. Got a fair number of Twitter followers. But there's almost half as many, or more than half as many people follow Irfan as follow the whole Vancouver Coastal healthcare system. Scott Gavora is a pharmacist at Cancer Care Ontario, who's also a terrific, very interesting guy to follow with very worthwhile things in healthcare. Just to put things in perspective, here are the followers for LeBron James, Justin Bieber, and Steve Nash, which is a bit depressing because in my view they're in opposite order of who I would want to follow. And actually I do follow Steve Nash, and I do not follow Justin Bieber or LeBron, although LeBron's a pretty fantastic basketball player. But it is kind of sort of, we kind of think we're reaching a big population when we got a couple thousand Twitter followers. But anyway. So that was sort of a rambling, sort of kind of rather unfocused talk about patient involvement. Just to summarize I think personally, I think the JLA process, it's an evolving process, but it's one that if you're interested in involving patients in priority setting and research, I recommend to you. I haven't done it once. I thought it kind of worked really well, and I do think we're at the stage where we kind of got to be engaging patients in helping us set. And I'm not saying turn over the whole research priority setting agenda to them alone, but at least have them involved. Healthy debate. Any of you want to send in opinion pieces? We would welcome them. It's actually now a struggle just finding funding for it because it's actually not a research project anymore. So I'm kind of going around trying to find dollars. And just a little bit on where I think, I think we're not that far into social media in medicine, and I think we've kind of got to get there. And there's some scary parts to it. It's kind of uncontrolled, but there's also some really sort of exciting parts. You can reach a lot of people with it, and provide some really good information. So, with that, I'll end and take any questions that you have. Sure.
So I'm interested in the dialysis patients, how they felt about the fact that you didn't actually have a concrete place that the result of that exercise was going, and whether that mattered to them. Maybe you thought about it before, but you were just trying to rule that out.
Well, we actually gave them your address, actually. No. No, actually, they didn't. I mean, we kind of, when they said, what are you going to do with this? We said, we're going to share it with, the Canadian Institutes of Research, AIHS, Michael Smith, Kidney Foundation, and we'll broadly share it. We have no guarantee that people are going to pay any attention to it, but they seem to accept that, and there was sort of no pushback about, I think, frankly, they were just so thrilled to be asked, just like the citizens, actually, that they, and I think they trusted us that we would pass it on, and, the letter that you're going to get is signed by all 10 people on the steering committee, and, they're still looking at the manuscript. It's not just the scientists that are looking at the manuscripts now, everybody is, so. Up there, yep. No, you. Yeah.
How do you propose? And I first of all, I'm fully supportive of the idea of both having citizens and having patient input. And so, just a bit of background, when the Center for Menstrual Cycle and Ovulation Research started now 11 years ago, as soon as we could, which was about less than a year later, we launched a website.
Mm-hmm.
And we've never had any formal funding for that website, and yet it has reached every continent and gets about 12 or 1,300 page views a day. So I totally believe in the idea, but how do you fund it?
Well, that's a really good question. The Healthy Debate was initially funded by money from the CHR. We actually submitted a FISI grant, and it's the only time in my career I've ever been triaged. And so, and the message was, this is not, and we actually had an evaluation in the grant, but the message was, this isn't research anymore. You kind of look like you got a website that's doing pretty good stuff, but don't come to the CHR. So that was a bit, I've never been triaged before, so that was a bit like, whoa. But, I can get it. That's fine. So we're about to, actually, one of the things I should have mentioned, there's a donate button if you're on the website. But one of the things we're putting together, we're going to work with our foundation at St. Mike's to approach, a variety. We might approach some foundations. We're going to approach, actually, we've just decided that we are, beggars can't be choosers. We're going to approach the OMA and the ministry and the Ontario Nurses Association. We would kind of preferred not to do that, but I think if we approach many of those groups and we get a lot of funding from, people, and we would insist upon a letter that would say, we're giving you this funds, but we're not going to try and impact the content of the website, and we'll put that letter up on the website. But we're going to have to get out there and raise funds. And part of me is sort of wondering is like, how long do I want to do that? I certainly, I'm enjoying this enough, and I think the website will develop enough that I'm willing to spend the next 2 to 3 years of my career doing that, and then we'll sort of see how it goes. Yep. Yeah, you and then Alan. Yes.
What's the experience with the donation?
Well, that's a good question. I think the first month we were almost shocked. We got $4,800, which I frankly didn't think. And I think then the second month, I think I just heard it was sort of $1,800. It's not going to be enough. I mean, we've got two writers who write the articles, edit the stuff. Obviously, keep an eye on the comments to make sure that we kind of take. So, it's not going to be enough to sustain it, but it's not nothing. So, and what we'll probably do is every 6 months send out a little blitz to our email followers and sort of tell them how poor we are. No?
A few years ago.
Yeah.
One of the things that came out was this patient family factor in changing the system. But what I was shocked to see is that the literature was almost entirely focused on and not on the patients themselves. Real literature on how do you get acting and
That's a really good question. I mean, not a lot to be honest. I mean, the things that sort of go through my mind is that I do worry sometimes that, and I don't mean this to be a pejorative comment, but some of the sort of patient advocates almost become professional patient advocates, and therefore, and you know, with the Citizens Council, had we continued that, we were getting ready to rotate, you know, half of them off and half of them on. So one way of doing that is I think to try and bring, you know, new faces into the conversation. You know, in terms of the cold face, I mean, those tweets about, like, the care of my dad, it really sucks, are kind of pretty cold-facey, right? You know, trying to address those. Now, that's obviously only kind of raising up the kind of bad apples, and there's problems with that. But it's a good question, and I don't have any, you know, magical solution, I'm afraid.
You know, James, I had a question on what kind of data would be needed to support that these types of engagement actually do make a change for the better.
Now, are you talking about the research ones, or are you talking about the health system?
What kind of data should we be looking at to demonstrate significantly that patient engagement, citizen engagement makes a change, makes a positive change, whether it's financially or patient satisfaction? Maybe that's one of the answers, actually.
Well, I mean, I think it's a good question.
Because you said there was no data to show that the individual patient made a change.
Well, the involved document that I presented, that I flipped up there, is actually a systematic review. It's probably about 3.5 years old now, of, you know, all the evidence on patient involvement in research and its impact. And as you would expect, there were no RCTs of randomizing, or there might have been one or two maybe on committees or whatever, but it was largely qualitative. But, you know, the older I've gotten, the more respect I've actually developed for qualitative research. I mean, the reason I started this talk with a story is I think that's a pretty compelling story. And, like, I'm fairly convinced if the oncologist at the Mayo is telling me they would never have done that study without Michael demanding it, and an absolute risk reduction in mortality of 9%, there's quite a few lives saved there, right? So, you know, I think if you put a few of those stories together, I think that starts to become more compelling. I know that in the UK, the National Institute of Research is now funding some studies that came out of the JLA process that they would never have funded before. So I guess one thing would be then to say, you know, what happened with those, and, you know, was there a positive impact? And if there was, then, you know, the CHR, if you were to talk to Alain Baudet, and he thinks about patient involvement, he immediately thinks of CCSVI and multiple sclerosis, where, you know, you could argue that didn't go that well, and maybe actually lots of money is being put into research that's not going to be that fruitful. But I would point out that it costs pharma $1 billion to make one new drug. So it suggests to me that in the way we're developing drugs now, there's lots of places we go that isn't fruitful, right? So I don't have a lot of patience for someone saying, well, patient suggested this, we did it, it didn't work. Well, guess what? There's lots of stuff in the conventional biological world where we go down routes that we think are going to be really effective.
Billions.
Yeah, exactly. Like, that's why it costs $1 billion to make a drug, because you go down many, you know. Around the citizen engagement, I think, you know, boy, that's hard, survey, but it's probably going to be qualitative, to be honest. Yes? Thank you.
Are they interested in being involved?
Yeah, that's a good question. I mean, you know, my sense is it's probably fairly variable. So, you know, we were pretty clear about that. The only thing we were asking them to be involved with was this process. My gut feeling is many of the patients would have sort of said, you know, that was I mean, I got actually a lot of emails from people after they got home saying, wow, that was great. I actually had 2 or 3 emails saying that was the best, they call it a meeting I've ever been to. So, I think they really enjoyed it. I think, some of them found it really tiring and exhausting. And probably would say, well, I've done my bit. It's time for someone else to step up. And I think others would say, yeah, I really want to continue to be involved. And it's probably true of the nurses and the social worker and the dietitian we had come as well, right? So I think the answer is variable. But it doesn't bother me that they would sort of say, I've done my thing and that was good, but I don't want to do any more. Pardon me? Have you had experience in having somebody? Well, I've only done this one JLA process, and at least in the UK, they go from multiple sclerosis to vertigo to cleft lip to type 1 diabetes. So they're not going back to the same community again. All right?
Well, we can continue this
We can.
next door, and I'd like you to join me and thank you again.
Thanks.